AALL1731 was a randomized trial of the Children's Oncology Group, co-led by myself and my co-chair, Dr. Rachel Rao. And what the study did is it took all children with standard risk B-cell ALL, and those children who were at either an average or a higher risk of relapse, which we call standard risk average and standard risk high, were randomized to receive either standard chemotherapy or standard chemotherapy with 2 cycles of blinatumomab. And blinatumomab is an immune agent that targets CD19 on the surfaces of B cells and then recruits the patient's own T cells to attack and kill those leukemia cells. And the study at the first planned interim analysis was shut down by the Data Safety Monitoring Committee because the efficacy results were extremely good with blinatumomab. So, for example, the standard risk average group of patients who received chemotherapy alone had a 3-year disease-free survival of 90%, whereas those who received chemotherapy and blinatumomab had a disease-free survival of 97.5%, so quite a substantial increase. And then in parallel, the standard risk high patients, those at a higher risk of relapse who received chemotherapy alone, had a disease-free survival at 3 years of 85%, but that increased to 94% with the addition of blinatumomab. So these results to us indicate that for most children with B-cell ALL, the addition of blinatumomab to standard chemotherapy now represents a new standard treatment, that most children with ALL who do not already have a favorable, an extremely favorable outcome with chemotherapy alone should be treated with chemotherapy plus blinatumomab. Yeah, it's a great question. So I think I'll divide the answer into 2 parts. The first part is we know, as you referenced, that there are certain side effects that are associated with blinatumomab, things like cytokine release syndrome and neurotoxicity. So thankfully, the rate of grade 3 or higher CRS or neurotoxicity was very low. It was in the order of 1 to 3%. Now, I will say that this is a group of children who had very low, very minimal disease burden at the time that they received blinatumomab, and we know that that has a lower risk of side effects associated with it. The other caveat to put there is that these children were all less than 10 years old, and there's a little bit of data out there to show that the risk of neurotoxicity might be higher in older children. So again, take that with a grain of salt, but in this population, those side effects and toxicities were actually, thankfully, very, very rare. The one thing to note, however, is that we did see a higher risk of grade 3 sepsis or catheter-related infections in the standard risk average patients who received chemotherapy and blinatumomab versus those who received chemotherapy alone. Now, the interesting thing about that finding is that those events, those sepsis and catheter-related infection events, didn't really seem to happen during the blinatumomab administration itself, but seemed to be an increased risk in the subsequent chemotherapy cycles. So we're in the midst of doing extra analyses to try to get more information about that, but we hypothesize that that may be an interaction between the B-cell aplasia that you get with blinatumomab added on to the effects of chemotherapy. Thankfully, the rate of grade 4 or grade 5, so serious sepsis or infections, was not increased in children who received blinatumomab and chemotherapy versus those with chemotherapy alone. Yeah, it's a great question. So, this population, as I said, was a less than 10-year-old population, and the results have been published today, so I think that becomes now standard. At the same time, earlier this summer, another New England Journal paper was published on the success of adding blinatumomab to adults 30 to 70 years old. So technically, we don't yet have data for that in-between population, the 10 to the 30-year-olds, but it's important to know that those, at least in North America, older children are treated with the same types of backbones as we studied in this group, and it's difficult to hypothesize that blinatumomab would work in less than 10-year-olds and over 30-year-olds but not work in between, but certainly you could say that we need more data there. I think the more exciting thing potentially is we know now that blinatumomab is very effective in in preventing bone marrow related relapses. So one question is, can we actually start to get rid of some of our chemotherapy? Do we need all that chemotherapy when we have the effectiveness of blinatumomab in play? Our study just added blina. It did not take any chemotherapy away, but we're in the midst of now designing studies that will see whether we can maintain these very, very excellent outcomes while taking away some of the chemotherapy and the short and the long-term effects that are associated with that. The last thing I'll say is that blinatumomab does not have activity in the central nervous system. And so even though the rate of CNS relapses was very low on our trial, it was not different in the patients who received chemotherapy alone versus chemotherapy plus blinatumomab. So one area of future study is going to be, how do we go into this new world with taking away chemotherapy, maintaining outcomes, but also preventing some of the CNS relapses, which blinatumomab did not do.